I've been given, so thanks to the organizers for inviting me to give this lecture. So this is an important topic. Dr. Chetan has made my job easy because he's covered most of it. So I'll try and skip those slides. So OP poison, why is it important? Because it continues to be a problem, not just in the rural Indian or developing countries. Even in America, I think every year thousands of people get admitted to ICU. So just not for clinical management, but also exam point of view. Wherever you go, most of the time you'll end up having one of these cases. Why that is, this slide just kind of summarizes, because it's so cheap and easily accessible, so it continues to remain a problem. Housewives and farmers are kind of, they both are kind of equally getting access to these things. The main reason is in urban India, now all these for road sprays and all these things which are less toxic, but it's easily available. That's why it's still a problem. So most case series, around 80-85% is suicidal intention, and accidental is because the farmers, while they're spraying, they're exposing themselves to these toxins. So these will be my main headings in this talk. So we'll just go through one by one. And as I said, most of it is already being covered by my fellow speaker, Dr. Chetan. So, so as we all know, mainly agriculture and household chemicals are the one which people, they get exposed to. Other things are not so common, commonly accessed. Classification based on the toxicity. So it's been classified as highly toxic, less toxic, and intermediate toxic. So we all know the agriculture insecticides are the one which are very toxic, which are the parathions. And the household sprays, the one which normally in urban India, what we normally see, it's not, we get referred to from other places as well, is the malathions. Something in between is the chlorpyrifos, which is used in animal insecticides. So WHO also has a classification that's based on clinical severity, as the slide says. I won't read it. Based on the RBC cholinesterase levels, which we will allude to in the later slides. The severe ones is when the RBC cholinesterase levels are very, very low, less than 0.8, where the sickest patients whom most of us would have seen. The mild ones are when cholinesterase levels are basically about 2 units per liter. They are the one who have some clinical features, but something in between is the moderate. So pathophysiology, again, you guys know, what does it do? It inhibits acetylcholinesterase. Once that's inhibited, there's a lot of acetylcholine. When there's a lot of acetylcholine, there is overstimulation of nicotinic and muscarinic receptors. And most of the clinical features are because of that, which, as Dr. Chetan has covered, I'll just briefly touch upon that as well. So it's called toxicokinetics, just covering the same thing with a different heading. So as we all know, it can get absorbed through the skin as well. So when patients come, especially in the emergency, you just have to make sure if there's any contamination that the whole clothes, everything should be kind of taken out, and patient should be washed with soap and water. That's the recommendation. The WHO document says that as well. So again, which we already covered, the pathophysiology of it. The one thing I want to cover is the aging. So aging is just a phenomena which happens in context to acetylcholine, to OP poisoning, where depending on the chemical, when it binds to the acetylcholinesterase, it forms a conformational change and it becomes irreversible. The diethyl compounds have, they quickly do that. The other compounds are slightly delayed. That's the reason why WHO still recommends the PAM, the prelidoxime. Again, the controversial, but WHO still recommends it. So clinical picture, it can happen, as you know, depending on the compound, in minutes or hours. The one minor point about children is, children, for some reason, they tend to kind of show more nicotinic kind of clinical features than muscarinic, which we normally see, other than the muscle weakness in adults. So sympathetic, parasympathetic, neuromuscular junction, and because most chemicals go through the blood-brain barrier, the central effects also you see. So this again, the nicotinic, mnemonic, the week of the day. So I won't repeat it. So you know this, so just remember. So mainly the hypertension tachycardia is, you know that nicotinic receptors are there in adrenal glands. You don't see that, but there are other reasons why you would see tachycardia as well. Muscarinic effects, two mnemonics. So important thing to remember, everything is excessive, as Dr. Chetan said. One thing, bradycardia, bronchoria, bronchospasm, they are the important ones. So you have to remember, and everything else, you know this. So I won't bore you by repeating these things. So just to kind of have some kind of classification for weakness in the literature, the weakness in context to OP poisoning is kind of labeled as type 1, type 2, type 3. The type 1 is the initial cholinergic, what happens because of persistent depolarization because of excessive acetylcholine. So that's called type 1. So generally, most of them recover after a certain time. What happens later, after 24 to 96 hours, which we will talk again in the next slide, is the intermediate syndrome. Why is it called intermediate? Because there's type 1 and type 3, something in between is intermediate. Okay, so that's why it's called intermediate syndrome. Type 3, not all chemicals you have OP-induced polyneuropathy. Chlorpyrifos is classic, but some other chemicals it happens as well. We'll just touch upon these things in the next slide. I'll cover the treatment part, but it's not much in this, but the rest of the treatment part we'll cover later. So intermediate syndrome, as I said, it generally patient recover from the initial weakness, and again you tend to see the neck muscle flexion gets kind of and proximal weakness. If you're monitoring the deep tendon reflex, that gets reduced. There will be some cranial nerve involvement. All these things you tend to see, but remember there is no sensory involvement in intermediate syndrome, unlike the OP-induced polyneuropathy. Nobody knows why it happens. There are various theories. Treatment-wise, just have to make sure, because it can make respiratory muscle weakness and insufficiency. In ICU, we're all good at kind of recognizing that. If that is kind of managed and supported, everybody kind of recovers from this. So that's the most important thing. Physiotherapy, rehabilitation, recognition of respiratory weakness and failure. That's the most important thing. OP-induced polyneuropathy, again, this is slightly different. Chlorpyrifos is the classic chemical which causes it. Not every chemical causes this, and there are plenty of OP compounds, so others can also cause. So remember, this is unlike intermediate, it's distal. So classic description, as it says in the slide, it's a stocking glove. There is sensory involvement, again unlike intermediate syndrome. It starts with paresthesia and there will be some weakness. So this happens 2 to 4 weeks after the initial exposure. Other thing to know about this is again supportive care, recognizing the problem, physiotherapy, rehabilitate, but this has not everybody recovers fully in this. That's the problem with the OP-induced polyneuropathy. A lot of things have been tried, including steroids. Nothing is as good as the standard of care, which is just to support and physiotherapy rehab. So nothing is recommended to be used for these things. Yeah, this is the slide. Okay, I didn't change it. So clinical features, the central, as I said, most OP compounds, they cross blood-brain barriers. So these are the things which can happen. Like anything else, anything which stays in the central nervous system after a certain time, it causes problems, not during the ICU, post-ICU stay as well. Like other compounds, even OP compounds, the same thing happens as well. The important thing is anxiety, confusion, and the seizure, which again, my previous speaker said, the benzodiazepines, unlike in ICU where we go for haloperidol, here is one condition where you should go for benzodiazepines. So other things which you should know as well as a complication which can happen with OP poisoning is the cardiac, which can be life-threatening. The most common is obviously symptomatic bradycardia and cardiac arrest. So that is the most common. The arrhythmias are common as well, because the metabolic and electrolyte abnormalities comes with the problem. With all the clinical features, the metabolic issues are very, very common. The other tachycardia, hypertension, it happens as we have already spoken about. As I said, when there is exposure of a toxin in the brain for a certain amount of time, obviously, once they recover the acute phase, they always have some issues with their neuropsychiatric condition. So these are the things, including Parkinson-like symptoms can happen as well. So investigations, mainly the diagnosis, a good history, the exposure history, and the clinical, and obviously there is a typical smell is described in the literature as well. The one add-on complementary thing we can use is the RBC cholinesterase, which I don't have an access to, and none of us have access to in any of the hospital labs. But you know, we can use plasma butyryl cholinesterase as a kind of a diagnostic help where the levels of that can be reduced as well. But thing to remember is plasma or butyryl cholinesterase levels can be reduced with infection, malnutrition, and all the things what we see, and the inflammations what we see in the ICU as well. Whereas red cell cholinesterase is not just for diagnosis, as the patients get better, the levels also go up. So you can use it to monitor the response to treatment as well. So treatment-wise, so like any, which we've been stressing throughout this course, like any critical ill patient management, don't forget, you know, just don't go to the specifics of the management. It always starts with general. General always is assess. I always tell my registrars, don't just say ABC, just say I'll assess and stabilize. That's what we do, assess and stabilize ABC if indicated. So general ICU care, however you want to say it, always comes with ICU stay, fast hugs bid. Now there is a fast hugs bid, please, and all the, there's new publication as well. So I think we will be using please as well at the end of it, maybe later. Infection control comes with ICU care. You know, we are the kind of, what shall I say, what's the word they use in the, near, what's the word I was looking for? I can't get the word. Oh no, near, in the pubs and all, the big guys will be there. Bouncers. We are the bouncers for infection control. God, I prepared for that so much and I forgot. Okay, specific treatment comes, you know, all these headings we'll cover. Before we go to the specifics of it, the few tips about ABC. The rule of thumb is, you know, securing airway, general indication, but important thing is remember the bronchoria, bronchospasm, and the sensorium and the respiratory insufficiency. So you should have a low threshold to secure airway because that's the one which kills the patient. So you just have to make sure, because if you support that well with a good ICU care, which we all do because it's a super specialty now, patients will, everybody survives. And, you know, no succinylcholine, as I said, I know, as my previous speaker has said, don't give it. The one practical point is always give the first dose of bolus atropine before securing the airway. Okay, that will kind of prevent the disaster peri-intubation. Decontamination, again, a very controversial topic in a way, because the European and American kind of consensus, they discourage gastric lavage, they discourage activated charcoal in all their consensus statements. But in the Indian context, anyway, when the cloth I've said, you know, you should remove and wash. Gastric lavage, 1 hour, they come in 1 or 2 hours, we should use it. Activated charcoal, again, within 1 or 2 hours, we should use it. But in clinical practice, what we see is the people do use not just the one dose, multi-dose activated charcoal as well. My colleagues use it as well. And, you know, in the literature also, there is some mention due for OP poisoning in a developing world. The guidelines for, again, the blockade of muscarinic activity, the mainstay of treatment is atropine, atropine, atropine. We end up using the whole stock of the hospital. I'm sure most of you must have, if you have seen a bad case, you would end up using the whole stock of the hospital. And we've had it once, and we had to use the whole stock of the hospital. So the WHO also recommends you give a bolus 2 to 5 milligram, 3 to 5 minutes. Yeah, you know, I think there are different ways of doing it. You do keep doubling it up to 5 milligram and keep giving it every 3 to 5 minutes till the end point is not your pupils, not your heart rate or blood pressure. End point is your bronchoria, bronchospasm. That's the WHO says. Some literature says heart rate of more than 80 and systolic blood pressure of more than 80, but the bronchoria and bronchospasm should be reasonable before you decide to reduce or start an infusion. The recommended infusion is you calculate the total dose, the 20% of it you give it over every hour as an infusion for 48 hours and then start tapering it. If there is a need, you continue it, because you taper it if there are again muscarinic effects you see, you increase it and use it as long as you need. So endpoint, as I said, bronchoria and the reduced episodes of bronchospasm. So some literature says heart rate of 80 and systolic pressure of 80 as well. So atropine toxicity, you will see it. Most common, again, it's been touched upon, agitation, delirium, you will see. And you will also, other things, you might, hyperthermia, you will see it as well. So what to do, you kind of stop infusion. That's different. WHO says stop infusion 30 to 60 minutes and then start with 70-80% of the dose which you had started previously. So if really it's causing you a bother, you'll have to forget about the central effects and you'll have to consider glycopyrrolate. So when you consider glycopyrrolate, one, the severe atropine toxicity, or you have run out of atropine in your hospital and waiting. You know, if I'm working in Fortis, I'm waiting for the Manipal atropine to come to me, or Apollo Manipal atropine to come to me. Till then, I use glycopyrrolate. How one way of using it, and recommended way is 7.5 milligram 200 ml and keep titrating it. Pralidoxime, yeah. So again, controversial kind of literature, but WHO recommends it because what it does is, as it says in the literature, it reverses the cholinesterase inhibition by oximes. So as I said earlier, diethyl compounds make it irreversible quickly. Some compounds will take few hours. So the WHO says within 48 hours you give it. How do you give it? You have to give it as a bolus 30 milligram per kg per hour. Important thing to remember is it can cause cardiac arrest and it may cause cardiac arrest. So you have to give it very slowly over 30 minutes. And arrhythmias, those are the two important things. Other things are not so important. So you have to be very careful when you do that. And then once you give the bolus dose, you give 8 milligram per kg per hour. You give it as an infusion. Again, the 48-hour kind of recommendation. And then you reduce it. But if there is a rebound issues, and if you think it's working, they've recommended that you can continue using till you need it. So toxicities which I was mentioning about cardiovascular toxicity, mainly the symptomatic hypotension, so which atropine will use. Sometimes we'll have to fluid restate, use vasopressors, which we all do anyway. ECG, tachyarrhythmias, ventricular tachyarrhythmias is the life-threatening ones. You deal with it the way you deal ventricular tachyarrhythmias in ICU. CNS complication, again, agitation, delirium, seizures, they are the one which we normally see. So we go for diazepam or lorazepam, as we said. So WHO says give 10 milligram bolus and you can use 3 to 4 times a day. Respiratory complications, which I've touched upon. What kills is if we don't recognize the respiratory problem. So it's important to have a low threshold. I'm stressing on the same point again. So the other new therapies, what has been tried, depending on what the actions they have. Magnesium, the magic ICU drug. So that's been used for OP compound poisoning as well. Why? The people have established that it reduces the release of acetylcholines. When acetylcholines already, there's a lot, this inhibits in sympathetic and parasympathetic nervous system. Where there's good study, no. Whether people have used it, yes. Standard care and magnesium, will it make a difference? Nobody knows, but most of the patients end up getting some magnesium anyway in ICU. So should we use it? Yeah, why not? Clonidine, alpha-2 adrenergic receptor agonist, again, it tends to kind of inhibits the production and the release of acetylcholine from the presynaptic synapses. So should we use it? Are there studies? People have looked at it. You'll be surprised. Some 2 small studies, they have found some, in their opinion, it makes a difference. It helps. So, but nobody uses in a standard way. But sodium bicarbonate, does it use? You kind of alkalize the patient. There are studies, in animal studies, where mortality is better in animals. Nobody's, and again, you want to use it, and it's not a recommended thing. FFPs people have used, so fresh cholinesterases, will it help? Nobody knows. And OP hydrolases, peroxygenases, again, which breaks down the OP compounds, people have used it, and standard of care and that, no difference. Okay, I think that's it, the OP compound poisoning.